Welcome to the deep dive. Today we're tackling a pretty fascinating corner of psychology.
Yeah, we are.
It's all about how we classify some really personal, sometimes complex aspects of being human.
Exactly. Things like sexual function, gender identity, certain patterns of interest and behavior.
We're going to try and unpack the psychological frameworks around these.
Yeah.
Basically, give you a shortcut to understanding the core ideas.
Right. The key distinctions, maybe some surprising elements.
All without getting totally lost in the jargon, hopefully.
That's the plan. We're diving into the established classifications, the concepts used in the field.
So, for you listening, the mission is to pull out that core understanding.
Make things clear, highlight what's really noteworthy.
Okay, let's start with sexual dysfunctions. When we talk about that category, what's the big picture, the main definition?
So the overall category, sexual dysfunctions.
Hmm.
It refers to a clinically significant disturbance.
A disturbance in what exactly?
In a sexual response or maybe the experience of sexual pleasure. But, and this is really important, context matters for diagnosis.
How so?
Well, it's not just about, occasional difficulties. A diagnosis really only applies if the symptoms can't be better explained by something else.
Like what?
Like a non-sexual mental disorder or maybe relationship problems, big life stressors, even substances, medications, or other medical conditions.
Ah, so you have to rule all that out first.
Absolutely. It's kind of a process of elimination.
Got it. Okay, let's zoom in then. Erectile disorder. What are the essentials there?
Right, erectile disorder. For the diagnosis, you're looking for at least one of three specific symptoms.
2 symptoms, okay.
Yes. Marked difficulty getting an erection, marked difficulty keeping it until, completion, or a really noticeable decrease in rigidity and firmness.
And this has to happen often.
Pretty much almost all the time, yeah, for at least 6 months. And crucially, it has to be causing the person significant distress.
Distress is key.
Always. It's part of what makes it a clinical issue.
Okay, persistent, distressing. What else is vital to know about diagnosing this?
Well, ruling out medical causes is absolutely vital, super important.
Like what kind of medical issues?
Things like diabetes, liver or kidney disease, multiple sclerosis, even smoking can have an impact.
Right.
And certain drugs, too. Some antipsychotics, antidepressants, high blood pressure meds, they can sometimes cause it.
Okay.
And here's a really interesting point.
Oh, yeah.
The complete lack of erections during REM sleep, the dream stage, if those are absent, it strongly suggests the cause might be more physical.
Wow, really? That's specific.
Yeah, it's a fascinating biological indicator. It points towards a physiological issue rather than purely psychological, shows how linked everything is.
That REM sleep connection is quite something. So, okay, medical causes are ruled out. It seems more psychological.
Yeah.
What then? What are the treatments?
Well, the first step is always that thorough medical checkup. Always.
Right.
If psychological factors seem primary, then cognitive behavioral techniques often come into play.
CBT. Based on whose work?
Largely derived from Masters and Johnson's pioneering work, actually. Their stuff really shifted focus onto the whole sexual response cycle.
Ah, okay. So what do these techniques target?
They aim to address specific behaviors, anxieties, like performance anxiety, that's a big one.
That worry about performing.
Exactly. Which can then make the problem worse, ironically. It also looks at unhelpful beliefs about sex and aims to improve sexual knowledge and skills.
Makes sense. And what about medication? Viagra, for instance.
Yes, sildenafil citrate, or Viagra, is often used. It definitely helps with achieving and maintaining the erection itself. But it's important to remember it doesn't directly affect desire. It works on the mechanics, not the underlying drive,
Right. Tackles the physical outcome, not necessarily the root cause if it's psychological. Okay. Let's move to genito-pelvic pain penetration disorder. Sounds difficult.
It certainly can be, yes. The diagnosis involves persistent or recurrent difficulties with vaginal penetration during intercourse.
What kind of difficulties specifically?
It could be marked pain, actual pain in the genital or pelvic area during intercourse, or even just attempts. Or significant fear or anxiety about the pain happening before, during, or after penetration.
Anything else?
Yes. Also marked tensing or tightening of the pelvic floor muscles during attempted penetration.
And like the others, it needs to be persistent and cause distress.
Exactly. Present for at least about 6 months, causing clinically significant distress.
Are there any factors, maybe from someone's past, that are sometimes linked to this?
Research does suggest a potential association, yes. a history of sexual abuse or physical abuse.
That's important to know.
It is. Now, it's crucial, obviously, not everyone with that history develops the disorder, but it's a factor often explored in assessment.
A very sensitive connection. Okay. Now, what about premature ejaculation? A term people probably know, but maybe not the specifics.
Right, premature or sometimes called early ejaculation. It's characterized by a persistent pattern of ejaculation happening during partnered sex within about 1 minute of starting vaginal penetration.
1 minute. That's quite specific.
It's the approximate guideline, yes. Or simply before the person wants it to happen.
Okay. And again, duration and distress.
You got it. Pattern present for at least 6 months, happening on almost all occasions, and causing significant distress or frustration for the person.
So definitely not just the odd time, but a consistent bothersome pattern. How is this usually treated?
Sex therapy is often pretty successful, actually.
Using what kinds of techniques?
Well, sensate focus, which we mentioned indirectly before, shifting focus away from orgasm onto sensation and connection, that helps reduce anxiety.
Okay.
And then specific behavioral techniques like the start-stop method or the squeeze technique, those are designed to help increase control over the ejaculatory reflex.
Interesting. Is there a biological link here too?
There is, potentially. It's been linked to lower levels of the neurotransmitter serotonin.
Serotonin, really?
Yeah, which plays a role in regulating lots of things. Because of that link, sometimes SSRI medications, antidepressants that boost serotonin have been found helpful.
How do they help with ejaculation?
By increasing serotonin, they can sometimes influence the sensitivity of that ejaculatory threshold, maybe delay it a bit.
Fascinating how biology and psychology weave together here.
Yeah.
Okay, let's shift gears a bit. Gender dysphoria. This feels like an area where clear understanding is absolutely vital.
Absolutely critical. And right off the bat, it's crucial to know the diagnostic criteria are different for children versus adolescents and adults.
Why the difference?
It reflects the huge developmental changes across those life stages, how identity forms and is expressed.
Okay, let's start with children then.
Yeah.
Gender dysphoria in children. What are the main indicators?
The core thing is a marked incongruence, a mismatch between the gender assigned at birth and the gender the child experiences or expresses.
A mismatch, okay.
And this is alongside a strong desire to be the other gender, plus at least 6 specific symptoms.
6 symptoms for how long?
They need to have persisted for at least 6 months and be causing significant distress or impairment in the child's life, school, friendships, etc.
Can you give some examples of those symptoms in kids? What might that look like?
Sure. It could be a strong, consistent preference for, say, clothes usually worn by the other gender,
Okay.
or wanting to play roles of the other gender in make-believe play. A strong preference for toys or activities typically associated with the other gender,
Right.
even preferring playmates of the other gender. And on the flip side, maybe strongly rejecting toys or activities typical for their assigned gender.
So preferences and rejections.
Yeah.
Anything else?
Yes, also maybe expressing a strong desire for the physical sex characteristics associated with their experienced gender.
I see.
And there's also a specifier, a note in the diagnosis, if the child also has a condition like a congenital adrenogenital disorder or another disorder of sex development, acknowledging that complexity.
That gives a clearer picture for childhood manifestation. How does it change for adolescents and adults?
The fundamental piece is the same, that marked incongruence between assigned and experienced gender.
But the symptoms?
The number required is different. Instead of 6, it's at least 2 characteristic symptoms.
2 symptoms, also for 6 months and causing distress.
Exactly. Minimum 6 months persistence, causing clinically significant distress or impairment.
What kind of symptoms are characteristic in adolescents and adults?
Could be things like that marked incongruence showing up in relation to their primary or secondary sex characteristics like genitals, breasts, body hair.
Okay.
A strong desire to be rid of those characteristics, maybe through hormones or surgery.
Right.
A strong desire for the characteristics of the other gender. A strong desire to be the other gender and be treated as such.
And maybe internal feelings?
Yes. Also a strong conviction that they have the typical feelings and reactions of the other gender.
And are there specifiers here too?
Yes. Similar to children, there's one for co-occurring disorders of sex development and also a specifier for being post-transition.
What does post-transition mean in this context?
It means the individual is living full-time in their desired gender role and has undergone or is preparing for at least one cross-sex medical procedure or treatment. It reflects that journey.
That really highlights the different paths and experiences. What about the general course, the prognosis? What does that usually look like?
Well, for kids referred to clinics, the onset of noticeable symptoms is often quite young, maybe ages 2 to 4.
Wow, that early.
Often,
Yeah.
yes. But whether that dysphoria persists into adulthood, that's quite variable.
Doesn't always continue.
Not always, no. And the data suggests it might differ based on assigned sex at birth.
How so?
For those assigned male at birth with childhood dysphoria, studies show persistence rates into adulthood anywhere from, say, 2% up to maybe 30%.
That's a wide range.
It is. For those assigned female at birth, the reported persistence rates seem a bit higher, maybe 12% to 50%.
Interesting difference.
It is. And another interesting point. Among those whose dysphoria does persist into adulthood, most report being sexually attracted to individuals of their natal sex, their assigned sex at birth.
Okay. Those variations are fascinating. Suggest complex pathways.
Definitely points to an interplay of biological, social, psychological factors shaping identity over time.
Now, what's absolutely key when differentiating this, especially in kids, from just kids being kids?
Ah, yes, crucial distinction. Gender dysphoria has to be carefully distinguished from simple nonconformity to gender stereotypes.
So a girl being tomboyish or a boy being sissy-ish?
Exactly. A child who just doesn't fit neatly into traditional gender roles for their assigned sex isn't necessarily experiencing gender dysphoria.
What's the critical difference then?
The difference is that persistent, intense feeling of incongruence between assigned and experienced gender, plus the significant distress or impairment it causes. It's deeper than just preferences. It's about their core sense of self.
That distinction feels incredibly important to grasp. Okay, let's transition again. Paraphilic disorders. This category can sometimes, well, bring up questions and stigma.
It certainly can. So the overall definition we need here involves intense and persistent sexual interests that are outside the typical patterns.
What's considered typical generally?
Generally, typical interest involves, genital stimulation or preparatory stuff with consenting, physically mature partners.
Okay, so paraphilic disorders involve interests outside of that.
Yes. And for these less common interests to be classified as a disorder, one of two things must be true.
Okay, what are they?
Either the interests themselves cause significant distress or impairment in the person's life, social, work, etc., or the sexual interest involves actual harm or a clear risk of harm to other people.
Right, so it's not just having an unusual interest, it's the distress or the harm risk component.
Precisely. That's the crucial differentiator for it being a disorder.
Makes sense.
Yeah.
Can you give us some specific examples within this category?
Sure. There are several recognized disorders. Maybe today we can touch on, say, frotteuristic disorder and transvestic disorder as examples.
Okay, sounds good. Let's start with frotteuristic disorder. What are the defining characteristics?
Frotteuristic disorder is about intense sexual arousal, specifically from touching or rubbing against a non-consenting adult.
Non-consenting, that's key.
Absolutely paramount. This arousal shows up as recurring, intense fantasies, urges, or actually engaging in the behavior.
And for it to be a disorder.
The person either has acted on these urges with someone who didn't consent, or the fantasies and urges themselves cause significant distress or major impairment in their daily life.
Okay. Is there a typical age of onset?
It often starts in adolescence. Interestingly, the frequency of the actual behaviors sometimes seems to decline as people get older.
The non-consent aspect is really central there. Now, what about transvestic disorder?
Okay, transvestic disorder. This involves cross-dressing, wearing clothes typically associated with the opposite gender, but specifically for the purpose of sexual arousal.
So the arousal is the driver.
Yes. It manifests as recurring, intense fantasies, urges, or actual cross-dressing for sexual gratification.
And the disorder part comes in when?
When these fantasies, urges, or behaviors cause clinically significant distress or impairment in social life, work, other important areas.
I see. Is this seen across genders?
It's reported almost exclusively in individuals assigned male at birth. And interestingly, the majority identify as heterosexual.
Really? Heterosexual?
Mostly, yes. Some might have occasional sexual interactions with other males, but often specifically while cross-dressed as part of that arousal pattern.
So the cross-dressing is tied intrinsically to the arousal, and it's causing problems, not just about gender expression.
Exactly. That's the distinction for this specific disorder.
Given the nature of these paraphilic disorders, what are the general treatment approaches used now?
Well, historically, things like in vivo aversion therapy were tried pairing the stimulus with something unpleasant.
Did that work?
Research suggests limited, often short-term benefits at best. It's not really a primary approach now.
So what is used?
Current approaches lean heavily on cognitive behavioral therapy, CBT.
Okay. How does CBT apply here?
It often combines cognitive strategies like helping the person identify and challenge problematic thought patterns, the distortions around their interests,
Right.
also focusing on building empathy for potential victims, and improving tolerance for difficult emotions that might trigger behaviors.
And the behavioral part.
That targets the fantasies, urges, and behaviors more directly. Things like covert sensitization, imagining negative consequences linked to the fantasy,
Okay.
or orgasmic reconditioning, trying to shift focus during masturbation from the paraphilic fantasy to a more appropriate one.
So a combined approach targeting thoughts and actions. Is medication ever used?
Yes. There's a medication, medroxyprogesterone acetate Depo-Provera. It can reduce paraphilic urges and behaviors in some men by lowering testosterone.
Does it work well?
It can be effective for some, yes, but a major limitation is that the benefits usually stop pretty quickly once the medication is discontinued.
Ah, so it's not a cure on its own.
Generally, no. Often used alongside therapy, not as a standalone fix.
Right. Well, we certainly covered a lot of ground today. Sexual dysfunctions, gender dysphoria, paraphilic disorders.
We looked at criteria for things like erectile disorder, genito-pelvic pain penetration disorder, premature ejaculation, then gender dysphoria, the different criteria for kids versus adults, adolescents, the course, and that crucial difference from just non-conformity.
And finally, touched on frotteuristic and transvestic disorders as examples of paraphilic disorders, plus general treatment ideas.
A broad overview of some complex areas.
And I think a really critical takeaway for everyone listening is that these are really intricate, sensitive issues.
Absolutely.
They require careful, thorough evaluation by qualified professionals. You really can't and shouldn't self-diagnose based on a quick overview like this.
Definitely not. Accurate diagnosis needs detailed assessment, and any treatment plan has to be tailored specifically to the individual.
So as we wrap up this deep dive, maybe a final thought for people to ponder.
Oop.
Think about this spectrum of human experience in sexuality and gender. That line between, typical variations which are wide and patterns that cause real distress or involve harm.
Yeah, it's a complex boundary sometimes.
How might understanding these classifications, even basically, help us have a more nuanced, maybe more informed, perhaps even more compassionate view on the sheer diversity of human sexuality and identity? It might also get you thinking about the ethical considerations, right?
Yeah.
Always come up when we talk about these sensitive topics.
A lot to reflect on there.
Indeed. Thanks for joining us for this exploration on the Deep Dive.